Good evening, everyone, and welcome to the American Migraine Foundation State of the Union webinar. Very shortly, I will be having our panelists introduce themselves, but I wanted to just let you know briefly why we're talking about what we are this evening. The American Headache Society published in March of this year what they call a position statement, and we're going to learn from our distinguished panelists what this is, why it was done, but from an AMF standpoint, we felt it was critically important information for our members and our audience to know about it. And just in a brief poll that we did, of our members who responded, only 50% are aware of this really important position statement. So we think this is going to be an exciting hour. I have two colleagues from the American Headache Society, Nim, our vice chair from AMF, and we're also joined by Lindsay, a patient advocate. So I'm going to pass it over to Dr. Kathleen Diggory first. Kathleen.
Hi, I'm Dr. Kathleen Diggory. I'm a professor of neurology and ophthalmology at the University of Utah, and I'm the former president of the American Headache Society, and I'm really excited to be here because I love the American Migraine Foundation, such a good partner with AHS.
Thank you. Dr. Hawker Singh.
Hi, everyone. My name is Rashmi Halkar Singh. I'm so happy to be here. I am on the executive board of the American Headache Society. I'm also on the editorial board of AMF. I'm also a mom of a teen with migraines, so I also bring that perspective as well. I'm happy to share this conversation with everyone tonight.
Okay. Welcome. Thank you. And Nim.
Good evening, everyone, and happy Migraine Headache and Awareness Month, and thank you so much for joining us alongside our esteemed colleagues and patient advocates. My name is Nim Singh, and I am the current vice chair of the American Migraine Foundation's Board of Directors. I'm also the former executive director of the American Migraine Foundation, and I'm also a patient living with migraine.
Thank you. And Lindsay.
Hi, I'm so honored to be here tonight, so thank you for this opportunity. I am a patient advocate. I went through the American Migraine Foundation's Emerging Advocates program, which was fantastic, and so I've continued to do some work with that program. I also do a little bit of freelance writing for other migraine organizations, as well as I'm just joining Migraine at School also, since I'm a teacher. That's something else that I'm trying to take part in, so love adding to the migraine space.
Terrific. Well, thank you, everyone. And so we'll begin with you, Dr. Diggory, to take us on the journey of how this position statement came to be.
Okay, so the American Headache Society is a society of providers of care for individuals who have migraine and other headache disorders. And our mission is to improve the lives of people impacted by migraine and other headache disorders, and to educate providers, healthcare professionals, and the public. And so to do that, we try to keep track of what's going on scientifically. We host meetings and we try to educate ourselves. Well, the CGRP monoclonal antibodies came out around 2018 for the public. There have been lots of studies before this time, basic science studies and clinical studies and things like that, but it wasn't available to us as clinicians. I take care of many people with migraine. And in 2019, the American Headache Society said, we need to talk about, okay, so these new antibodies, where do they fit into practice and things like that? And the first position statement came out in 2019. And this statement took what evidence we had. And at that time, we had some evidence, but we didn't have the evidence that we have today. And we had recommended that because it was new, people would have to have 2 or 3 preventives before they could try the CGRP monoclonal antibodies. Well, then more data came out, and in 2021, Dr. Jessica Alani, Dr. Rebecca Birch, and Dr. Matt Robbins published a second statement that tried to hone in on where these new treatments really are positioned, and again, it was kind of fail a couple of the old treatments. And remember, our preventatives before the CGRP monoclonal antibodies, antihypertensives, antidepressants, anti-seizure drugs, those were our Those are our frontline drugs, and they all have side effects and a problem with adherence. Well, as more data became available, and when we had town halls and the American Headache Society Board of Directors got together, and patients told us, as clinicians, we heard from our patients like, why do I have to fail 2 other preventatives? They're not even migraine specific. Why do I have to do this? And we realized that there was a real need to come up and again, reevaluate the data and come up with a new position statement. And so a task force was formed, and this task force reviewed all the migraine clinical trials, all the placebo-controlled trials, randomized trials, prospective trials, retrospective trials, and tried to get real-world evidence as well to come up with, okay, what is the evidence that's available to us today? And that's how we started with this statement. And this statement then tried to put in perspective that, well, CGRP monoclonal antibodies should be really a frontline trial. It should be a first line trial for any prevention of migraine, because there's so much evidence, and it's safe, it's efficacious, and the side effect profile is way better than a lot of the previous preventive trials. And in addition, patients liked it and adhered to the therapy, and it really made a difference in our patients' lives. And so that's why we put out this statement that if individuals have migraine days, more than 4 migraine days in a month, that we should consider a preventive therapy, and we would put the monoclonal antibodies as well as the small molecule targeting CGRP receptor molecules like atogepant and ramigepant in with the antibodies, which were erinumab, fremonizumab, galcanezumab, eptimizumab. And so we put out this statement. In the statement, we review the evidence that's available, and we did all the clinical trial evidence as well as real-world study evidence. And then in our discussion, we brought up how this fits in with comorbid conditions. Many patients get asked to switch medications because their insurance will no longer cover something, and then you have to change it again, and how this is detrimental, and then that preventative may not even work. What the long-term safety is, that we understand how this affects many different populations. And then we even dealt with cost. And here, I think this was really important. These medications are expensive. But if you take in the cost to the providers who have to go spend all the time to get all these prior authorizations, and then the patients, they miss work, they miss school, they miss their life. The cost is, there is a cost benefit here. So we tried to make an argument about the cost, and then we put forward this statement. We published it in our journal called Headache, and I think we can make this available to anybody who would like to read it. And that's how it came to be. And those are the wide, overarching main themes for us tonight.
Yeah, and it's very powerful to hear about this, because you're really, not only is it very scientifically solid, but you're listening to patients, you're listening to providers, you're listening to the American Headache Society members, and updating a position statement in not that long of a time, 2019, 2021, and again. So I think it really speaks to the dedication that American Headache Society has to improve the lives of those living with migraine and other headache disorders, as you say. So thank you. We'll move over now to Dr. Hawker Singh, and we want to get a sense of what is this position statement meant to the members and to providers. What have you been hearing? And I apologize, Dr. Singh is periodically going in and out of focus. We're having a little bit of trouble with internet, but we can hear her well. Thanks, Rashmi.
Sorry about the video situation. So absolutely, this has meant a really big deal to all of us who take care of patients. My other job is that I'm a clinician. I spend all day, most days, seeing people who live with migraine and other headache disorders. And I think for many of us who play that role, this position statement has meant a great deal. The American Headache Society really is the provider-focused organization for those who are involved in this space. And this was really meant to help those who are really doing that work. As Dr. DeGray mentioned, what we are hoping to do with this position statement is elevate the CGRP-targeted treatments as a first-line option. Not the first-line option, but a first-line option. And that's a really important distinction. Because when I see somebody who lives with migraine, a lot of my conversation with that person revolves around what is the best treatment for that person. So we'll be talking about medications, and we'll spend a lot of time talking about possible side effects and what that means for them in terms of what they can expect, possible side effects, what they can expect in terms of benefit, all of those different things, which, you know, one conversation with one patient may not look the same as it might for another patient. But before this update went out, I was not able to live up to what I wanted for my patient because I was restricted by insurance company. For a patient, I might say, well, I would love to give you this medicine because what I know about your life and your expectations and what you want to do, I think this medicine might be the best choice, but your insurance company requires that you try these other things first. And at this point, I think what it's made, the difference that it's made is that I can remove that barrier and we can really think about the needs of the individual patient in front of me. And I can put the options in front of me, these are the options that we have. These are all the different options that we have. And I think this might be the best option for you, and here's why. We still use those older medications because for many people, those might be the best choice, but for some people, these newer medications might be the best choice too. It just levels the playing field and it really allows us to take that patient voice into consideration to the fullest extent. And the feedback that we've received has been phenomenal. I'll tell you that clinicians have really expressed gratitude about that. I've heard from some insurance companies that they've made changes already. I mean, it's only been a couple of months, so not all of them, but some of them have been very responsive as well. So that's been really great to hear.
Yeah, I mean, it's phenomenal to hear that because this is really what, as clinicians and providers, but also as patients, we want to know that we have frontline access to what we and our provider feels is the right choice for us. And in the survey we did earlier, we asked patients if previously their insurance company had forced them to switch, medical switching. And 40% of patients said yes, they were forced to switch. And when we asked them how it worked, did it work as well, better, or worse than the other one, 80% of patients reported that it was not as good as the medication they were previously on. So I think in addition to helping us choose the right medicine first, this statement, as you said, insurance companies are making changes and hopefully they will realize that medical switching is not appropriate.
You made a big point to put that in because of exactly that point. You know, it takes so much effort, I think, to get somebody on the right medication for them. And it feels so good for both the patient and the provider to know that we finally have achieved that point where they're able to function and do all the things that they want to do for their life, only to find out that insurance company wants them to switch. I think it's important to note that as clinicians, we make the point that even though there are many medicines in the same class, how somebody does with one medicine does not predict how they might do with a different medicine in that class. So if the patient comes in and says, this medicine didn't work for me, we can still try another medicine in that same class and it might still be beneficial. Conversely, if a medicine helped, I don't know if switching will have the same degree of benefit. And it's not that great of a feeling when I have to tell a patient, your insurance company is requiring that you switch after we finally have found something that worked for you. So I really appreciate that comment that's in this update saying that if we find something that works for somebody, they should not be required to switch because it's really important that they stay on the medicine that works for them.
Yeah, absolutely. So that's like a fantastic update from our provider AHS side. And so Nim, can you take us into what it means for our patients, for American Migraine Foundation, and really why we're presenting it this evening?
Yeah, I think it's really important first to highlight the importance of the Migraine State of the Union. I think Dr. DeGray asked a few days ago, what is the Migraine State of the Union? And I think, for us at the foundation, we recognized a few years ago that there's been tremendous progress in the space. And our partners at the American Headache Society, our partners at other advocacy organizations have been doing a lot of work over the last decade. And with that recognition, Migraine State of the Union came into existence to close out MHAM, to celebrate the wins and what we're seeing. But I can't think of a more exciting closeout to MHAM than talking about this position statement from the American Headache Society, because it does have widespread implication in a positive way for our patients, for the patient community, as well as for our clinicians in reducing their administrative burden. When I think about the mission of AMF, I really think there are 5 key areas where this position statement will help us serve our patient needs. We've always been an organization dedicated to improving awareness and education and ensuring our patients are well equipped with information. So when they do show up to their providers' offices, they're making the best decisions and participating in shared decision making and being well informed about what's happening so that their care is then tailored to meet their needs, as Dr. Halker Singh mentioned earlier. With that being said, this webinar is really that first step to ensuring our patients understand, hey, there has been a review of all of the evidence to date, all of the clinical trial data, the real world evidence that we're seeing since these medications have been out in the market. And now there is a body of evidence from our clinicians at the AHS who say, we really stand behind this pathway to ensure that our patients are having their burden of disease reduced and getting access to preventive therapies. So I think that's our first task at hand, is ensuring our patient members, those that take care of individuals with migraine, understand that you can have a conversation now with their insurance provider or your healthcare provider and let them know you don't have to fail 4, 5, or 6 different therapies before getting to a targeted therapy. The next area is, I think, where we leverage our community partners. We have a lot of our advocacy organizations that we partner with that focus on policy change. And I think this is a really critical time to leverage concise information. The position statement is easy to read, it's understandable, but it lends itself to policy change. And we can now advocate with our payers, with our PBMs, with our policymakers, that it really is time to reduce the burden on the clinical side, but most importantly, improve the lives of patients impacted by migraine. And being able to have something as powerful as the position statement really positions all of our organizations to stand behind a firmer statement for us to be able to advocate and also to change policies that are impacting the decisions that payers are making. The other area that really touches on both missions for AHS and for AMF is in the area of research and development. When we're able now to see evidence come together and the position statements support the use of preventive therapies and first-line therapies before having to go through layers and layers of other medications, we're now able to understand how these therapies are working in our patients and our patient members, and then maybe think about getting closer to precision therapy, right? And thinking about how we're seeing the impact of these therapies, how much burden is reduced, how side effects are reduced, and then that will spur new interest and new funding to continue this research, because we've been sort of at a stalemate in the prior decade to this one in the therapies coming to market for people impacted with migraine and headache disorders. And ultimately, I think the biggest one that hits me closely, because I am a patient with migraine, is the community that we provide in our mission. Now we're able to speak with more informed education, more informed facts, resources, and really get information into the hands of our patients and provide that community that they may not have had because they were searching for information they couldn't understand. They weren't able to comb through the research themselves. And with this community that we're providing through AMF and our partner organizations, they now have a go-to place to call, email, reach out to say, hey, I am talking to my provider, or I am talking to the payers, and they're still not getting it. What can we do? And we're able to provide that support.
Yeah, no, it's all of that is absolutely true. And as you were speaking, and we'll get to you, Lindsay, just shortly, because it's really important to hear from the patients. But one comment I wanted to make was, I think from a patient perspective, this position statement really helps us to reduce stigma. So many of our patients have lived with migraine. They're taking an antidepressant. Oh, you must be depressed. Oh, you're taking an anti-seizure drug. Do you have some kind of seizure disorder? Oh, your headaches are because your blood pressure is too high. That's why you're on a blood pressure pill. And the fact that we have this position statement that is empowering patients and empowering providers to make the best choice, which may be one of the new targeted therapies, it may be something else, but they have the power to say, in this case, I'm choosing a medication developed for the brain disease migraine. And
you know,
stigma is key.
I would like to just emphasize that what's so exciting about the CGRP monoclonal antibodies and those GPANs, the small molecules, these are migraine-specific therapies. These are not antihypertensives, anti-seizure, antidepressant. I mean, they're attacking the disease itself. And I think that's something that helps me, seeing my patients, I'm excited to be able to offer a disease-specific treatment when they've failed these other things, and when I see new people, to be able to offer it as first-line therapy.
Yeah, I would also, exactly, and I would also add to that the quality of life improvement that our clinician partners are seeing. That was what creates advocates, right? Because if someone is seeing that their life is greatly improving because they're now on a therapy that works for them, their burden of disease is decreasing and hopefully steadily decreasing, or at least at a place where they're regaining quality of life, they want to share that story. They want to be able for others to get that same type of access, to regain that same type of freedom from what has been such a debilitating experience. And going back to Dr. Lay's comment about stigma, that's the key to reducing stigma, sharing patient stories, which we have Lindsay here with us.
Yes. So we'll move on to you, Lindsay. There are 2 parts. And thank you so much for being with us, because you're really why we all do what we do. Even the American Headache Society, which is a provider organization, its mission is to improve the lives of patients. So thank you so much for joining us. 2 parts. First one is about your journey to finding some migraine relief, and hopefully you have. And the second one is about your experience as emerging advocates. But let's start with your migraine journey, if you could share that a little bit with us.
Sure. I've had migraine for a little over 30 years, so this has been quite a journey for me, and I actually didn't get a proper diagnosis until I was 30. And so I think that played a role in my care. I also have epilepsy, and so that diagnosis kind of took preference over migraine. And so when I finally made it to a headache specialist, then my life started to change at that time. However, it has been a long journey. And so every medication that you're talking about for blood pressure, for depression, for all the things, I have tried all of them. And so when I think about that journey, it has felt long. And I hugged my doctor when I was like, oh my gosh, we found something else. And so as patients, it is life-changing, because we really are looking for something to improve our quality of life. And I keep saying, and it may come from my teacher heart, but I really believe every person should get to live the life that they feel called to live. And migraine has impacted every area of my life. I felt that I may have to stop teaching at some point. And so this is all just so exciting. But I also have been on the road, unfortunately, of the insurance battle in the prior authorization. And I've thought I just need to bring my neurologist some cookies or something, some coffee, because I just really appreciate the time I know that goes into that. I have also, unfortunately, had the struggle of being switched and it not working. And so over time, I have gone from episodic to chronic. And so that's a hard change to make, but we are fortunately finding things that are working. And so, you talked about people wanting to advocate. I think this is why advocacy is so important. And I think the stories that we tell will make the difference. The numbers don't always matter, but when we hear the real stories, I think that matters. And so that is so true as well. So I just encourage all patients also that you really have to advocate for yourself. So when you're saying that not all doctors are aware, I think everybody, I think we have wonderful doctors, but they are humans. So, it's good to share what you know and to work as a team. So I think that's really important. And then also knowing that the American Migraine Foundation has talking points and some additional support, I think is also important. This is not always an easy road to travel, but it's encouraging. These things are so exciting. I have been trying to broadcast that as much as I can. So I think that this is great. And we appreciate you as clinicians as well.
Oh, well, thank you. We appreciate you. And you raise a very good point that, again, back to the reason that we're doing this is we want our patients to be empowered. Every single physician out there can't be an expert in migraine. And if we go back to the reasons we are where we are is if you look at the average medical school, it's approximately 2, maybe 3 hours of teaching on one of the most common human ailments that they will ever see in their practice. So they arrive into their practice ill-equipped. So unless they take it upon themselves and do educational programs, the American Headache Society, or do reading, or hop onto the AMF website and learn a bit, patients have to take a role. And this is why, as you said, Lindsay, you want to come into that appointment prepared and knowledgeable. And we think if our patients know about this position statement, they can advocate for themselves. And so you are an emerging advocate. It's a fabulous program created by our program director, Heather Moran. Can you tell us a little bit about why and then what you became an advocate and what you've been up to as an advocate?
Sure. So the program was, I think, just an amazing experience. You start by getting some education, and so we're all speaking that common language, and I think that was an important piece prior to working on a group project. So I felt kind of like a nerd, but I was just taking all kinds of notes and making sure that this is the language that I'm using and that this is either confirming or changing what I thought that I understood about migraine. And so I really appreciated that piece of the program. And then we were placed in groups to create a project that would be on advocacy. And so that even in itself was helpful, because I think a lot of people in migraine feel alone, and they feel like they're, no one understands, or they just feel like they can't share their story. And so that was the perfect time to, one, feel like you had common experiences. Even if your journey was different, we all had migraine. And it also just really ignited a passion in me as we focused on telling our stories and how important it is to share your story. And sometimes that can be a little scary, but I think through transparency, we really make change and we help people identify. And we also, as we're seeing changes in the healthcare world, it is possible. And so I think that's really important to acknowledge as well. So I thought the program was wonderful. I really encourage anyone that's considering that program to take part. And so, asking what I've been up to, I feel like it really, like I said, ignited a passion. In addition to that, I did the Miles for Migraine Advocacy Training Program as well, and am still working on a project for them because migraine at school really focuses on children, which is very important, and obviously I have a heart for that. But what the missing piece is that we talked about is migraine for teachers. And so looking at the teacher side, and, school is a different world. I mean, I think all of our, professions they have their own specific things, but it's special. So it's just a different world. And so really trying to create resources for teachers. And when I spoke of the life I feel called to live, that was one piece of it. However, advocacy is as well. So in addition to that, I have a website myself, and I've continued to add to that, and then also to try to create information for patients and share my journey that is kind of from a patient's point of view, because I sometimes think that making sense of everything and, again, feeling like someone relates to you can be difficult. So those are a lot of things that I've continued to work on, and in addition, doing some writing as well for Miles for Migraine and the Association of Chronic Disorders. And so I've just tried to be in the migraine space all that I can. So
Amazing.
Lots of things. Yeah.
You're truly an amazing advocate, and we're so excited to hear all the great work that you're doing. And we know there are many patients out there who are really in a bad place, and they haven't found the right treatment, and perhaps they're not living the life that, as you said, that they want to live. So, but we know that they're here and they're supporting, and we appreciate all the work that they're doing. I think you touched on something that I'd just like to hear from all the panelists about, and that's basically around work. And the impact of migraine on work, and how do we make changes in the workplace? I mean, there's a lot of data out there that's the leading cause of disability, work absenteeism, not being able to get to work presenteeism, you're at work because you've run out of sick days, but you're really not doing your best. It's the leading cause in ages 15 to 49. So it's a huge problem in North America. And I'm just curious, we'll start with you, maybe Dr. Degree, any thoughts on what you see in your patient practice related to that?
Well, some of my patients, just motor through and try to go to work, and it's presenteeism a lot. And when I see that, I go, okay, what different preventative can I give them so that they have better control? I mean, whenever I see them struggling to get to work or stay at work, it's like a red flag, an alarm bell for me that I need to find something that's going to help them be at work, because that's what our job should be, is getting people back to their life and their work and what they want to do. Some people are so disabled that they can't work, and that is really a difficult problem. And I find the patients that have chronic migraine that have not been able to continue to work are a special group that are near and dear to my heart, because I want to get them back to work so that they can provide for their families and, of course, live the kind of life that they want to live. So as a provider, it's an alarm bell when people are having trouble at work. It means I need to keep working to find the best treatments for my patient and personalize it for their specific individual circumstance.
Yeah. Anything to add there, Dr. Hawker, saying about that, or from a clinician perspective?
I think that this update to the position statement will hopefully help with this, because Lindsay spoke to really allowing people to live the life that they want to live. And that really spoke to me, because I think if we can match, first of all, we do know that we have this big gap in care, right? Migraine steals so much from all of us. And we also know that migraine is not just the moment that we're having pain, but it's there all the time, because many people have migraine they're thinking about impacts their quality of life all the time, whether we are in pain or not. And also, we also know that many more people would benefit from being on a preventive medication than actually are on one. And these are days that we will never get back. We have just one life to live, and we really want to be able to live each day the way that we want to be able to live them. And to do that, I think, first of all, people who have migraine, if they are impacted by migraine, the American Headache Society recommends that we should not only be thinking about how often migraine is impacting them, but how is it impacting their quality of life. That really thinks about it from the patient perspective. So that's where the clinician should really be asking patients, how does migraine impact you? And take that into the consideration to think about whether that individual should be put on prevention or not. And then the second piece is, if we have to think about step care rather than what is the best medicine for that patient, that prolongs getting them back to living the life that they want. And I think eliminating that and getting the patient on the best medicine for them right from the get-go will allow them to live their best possible life and give them back their days. So that really spoke to me as well.
Yeah, and I think it's a great point too with, so many patients, and we see this clinically, and I know Nim and Lindsay, you've probably talked to other patients and heard this, but people will say, oh, I have 6 migraine attacks per month. And you really have to take the time and say, well, what does that mean? How long do they last? Oh, they last 2 or 3 days. Okay, your 6 has now become 18. And what about those other 12 days? Well, what do you mean? Well, how are they? Well, I'm not my best. I don't feel great. I think it's important for patients to understand that from a provider side, we want to know all of it. We want to know about the interictal burden in between those migraine attacks. How are you feeling? How long does the attack last? Maybe you need improvement in acute care, but I think what we're finding with these targeted therapies, which we now, thanks to the position statement, can choose first line, the burden goes down. The migraine attacks are less frequent, they're less severe, they're shorter in duration, and really importantly, people talk about those clear headache-free days. They never realized what a headache-free day was until they got on these therapies.
Yeah. And I think, go ahead.
Just one follow-up to that. And even if someone, let's say they feel clear between those days, let's say they have 6 days and they're like, they happen unpredictably, but the other days they feel clear. I think the problem is that that person might not know which 6 days in the month will be a migraine day. And therefore, migraines hang over their head all the time. And they may choose to give up opportunities. That might impact relationships with family and friends. That might impact job trajectories. And that can impact a whole lot of other things too. And if they feel more in control of their life because they're on better prevention, that has a whole ripple effect. And that's what I really like about matching patient to medicine right from the get-go. And we can do a lot more than what we've been doing.
And I would just add that patients should think about how many headache-free days where they have the headache-free and they're clear. In our last scientific meeting, we talked a lot about cognitive strain with migraine and how that affects just how we do. So we may not have the headache, but we are fuzzy in our brain, or we're light sensitive all the time, and we can't really think clearly. So it's really important to communicate with your provider, I think, about how many totally headache-free days do you have and how many cognitively free days do you have. And if you're not getting that, then you really want to have a conversation about, okay, how can I get that? And what should I be on to help me achieve what I want to achieve?
Yeah, therapies are not just good enough. Go ahead, Lindsay, sorry.
I was just going to say, I think those are such great questions to ask. I think sometimes people with chronic migraine are kind of in the mindset that this is just how it's going to be. And I think that's really important to recognize and to share that it doesn't have to be this way. And so that's one reason I feel so passionate about advocacy, is because when you've been in those rough seasons and then you've seen the difference, we just want people to know that it is possible and that change is here. So I think that's really important.
Nim?
Yeah, you know, what's interesting about the workforce and being impacted by migraine is that on the flip side, employers, you know, we know we're all part of organizations, we all work, you know, all of that. But the bottom line is what really employers are looking at behind the scenes and the costs, et cetera. And often, you know, doing this work, we hear, well, it costs so much to implement changes. But it doesn't cost as much as people may assume, number one. And number two, the cost to the organization per person impacted by migraine is close to $2,000 per year. And we know if 1 in 4 people are impacted by migraine, or 1 in 4 women, 1 in 12, et cetera, you know, that's a significant portion of a large workforce.
Yeah.
Now, when you do that math, and then you look at the low budget, low cost changes, the type of lighting you have, and the flexible remote work if necessary, changing shift work to be in the daytime, you know, being able to adjust your workstation, having water coolers and nearby, et cetera. Those are very minimal changes that don't even amount to that $2,000 amount per person impacted. But the return on investment is really, really large, because not only from a corporate standpoint, you're doing minimal for maximum productivity, you're also connecting with an employee who's felt stigmatized for so long. And now they feel like they can truly have a place where they can be their whole selves. They can show up to work. They can do the work that they really want to do, but have been afraid to speak up, that they might need that adjusted screen. They might need that dimmer light or that scent-free policy. So I think it's really just ensuring that the narrative, we all as advocates, as clinicians, when someone is showing up to your office and you're focused on getting them the right therapy, the other side of the equation is also ensuring that they know that they should speak to their HR or supervisors about these low-cost changes that can really have a huge investment and return on investment at the company, because there might be a neighbor 2 cubicles down who doesn't want to speak up, but now you might have a twofold impact on what you're doing and how you're advocating.
Yeah, I think opening the conversation is so key. Nim and I were chatting with some of our colleagues in the life science part of this world that we live in, and one of them was saying, you know, we we really focus in on migraine at our company. But when we held a seminar about it and we started to talk about it, people came out of the woodwork and said, hey, that's me. Because now that it was okay to admit that you have migraine, because this is a brain disease, it's not depression, lurking and causing headache, and talking to patients and teaching everyone in this world of migraine that it's not a headache, it's a brain disease. And as I say to my patients, headache is but one component of a migraine attack. There are all these sensory changes in light and sound and smell bother you. As Dr. Degree said, you're cognitively fogged, it's harder to function, you can't find words, perhaps you feel off balance. And so, I think we've really opened things up. And I think one thing that I've been thinking about, and I don't know what the other clinicians think, or I'm sure as patients and advocates, you would probably think as well, is our acceptable standard of doing well going to change? So previously in some research studies and even now as well, we're looking for a 50% improvement was kind of our goal. But I think this new era of migraine and the science and the medications is going to change that. I'm just interested in anyone's thoughts on what they think about that.
I'd ask Lindsay, if you said that you could only have 50% be 50% better, would that be enough? I don't think so.
It doesn't feel enough. And we have had those conversations over time. So, and I think that's again where that idea comes from. I've just got to live with this. And so, I went through that over time. And there were times when I was ending up in the hospital and being admitted because medications were not working. And I was having so many attacks. And so as we had that 50% reduction talk, I was like, well, it's not so much. I'm not ending there so many times, or they're not as severe. But just the idea that you can live this life and it doesn't have to be this way, I think is so important. So yes, 50% isn't really acceptable. So it's a great question.
I think the beauty of the updated position statement as well is prior to these targeted therapies, it was not only the question of is 50% reduction enough, but it's like of these symptoms and all of these challenges, we can get you maybe 20, 30, 40, 50%, but maybe only 2 or 3 of the long list of things that you're challenged by. Now with the preventive therapies and targeted therapies, we can say we can probably get you closer to that 90 or 100 and address almost all of your challenges. And that's the beauty, I think Dr. Halker-Singh was speaking about, the efficacy and that this is equitable and it's only fair to our patients that we do this for them. That is the most exciting thing for me, is that we are now able to not only say we can get past 50, but your list of most bothersome symptoms can also potentially, reduce or go away staying on this particular therapy.
Yeah, we're looking for better percent improvement for sure. Lindsay, were you going to say something?
No, I'm okay. Yeah, thank you.
Yeah, so I think that will change things. So, and we're getting down to the last few minutes here, but I wondered, Nim, if perhaps you might just touch briefly on what American Migraine Foundation is trying to do for prior authorization and how we see it as an important factor in helping our patients, who therefore then can help their providers, based on, you might touch briefly on the multi-stakeholder forum that we held, for example.
Absolutely. So, it's really important for AMF and our mission and serving our patient community to not only tackle the personal challenges, but the landscape challenges that our patients are dealing with. And that big challenge has been around our payer system and the prior authorizations, therapy, medical switching. And we convened about 1.5 years ago a multi-stakeholder forum that included clinicians, scientists, patients, patient advocates, our partners at the American Headache Society, our payers, partners as well, including a medical ethicist. And we really laid down a roadmap on what it is, what do we need to do collectively? So we're not pointing the finger of blame that it's the payers, it's the life science partners, it's our patients, it's our clinicians. what can we collectively do to move this needle closer to that ideal state of individuals getting access to therapies? They're not switched around, and they're also getting access in a timely manner. From that point onwards, there has been a lot of progress. One of the keys to that, AHS has solved for us by publishing this position statement, because it really, again, concisely lays out the importance of the evidence to make clinical decisions and that shared decision-making process with patients. The other piece of that is a patient playbook. Lindsay, you spoke earlier about you had to go through that prior authorization process. I'm sure during that time you were also teaching yourself everything you needed to know to jump through those hoops, to also communicate with your provider, to connect all the dots. And that's something we're hearing from a lot of our patients, and what was uncovered from our multi-stakeholder forum, that there's just a lot of burden. There's a lot of burden on the clinical administrative side with our clinicians. There's even more burden also on our patients, who for the first time see that there's a therapy in front of them that they potentially will do well on, but at the same time being debilitated by this brain disease, now have to learn what prior authorization means, how to write an appeal letter, when to call their doctor, who's also very busy meeting with patients. And all of that just creates this tangled web of confusion. And so this patient playbook is being developed by clinicians, our partners at AHS, by patients, by psychologists, patient advocates, and really taking a look at what does that process look like? What happens if A happens, and then what to do with B, C, or D, and connecting those dots and creating a map and a playbook for patients to navigate and be equal partners in this process. Where I feel this is really important is, again, going back to the concept that patients need to be equipped. They need to understand that they are the drivers of their healthcare. And even though there may be challenges, barriers, or red tape, there is a community that understands what needs to be done, and we want that information in their hands so that they can be on equal footing with clinicians and those that are making these decisions about the care that's impacting them most personally.
Yeah, and so stay tuned, because we're working on this, and we hope to have it to patients soon. And I think it just speaks again to the collaborative effort that, you know, the groups we represent here have come together and, you know, provided for patients. You know, a lot of patients will say, well, rightly so, you know, why do I have to do all this work, and why isn't it just easier for me? And gosh, you know, we certainly wish it were easier. You know, we live for the day when you could walk in and, you know, say, oh, you've got migraine. Well, I have this great plan for you. Just like you walk in now and the doctor finds high blood pressure. Perfect. I've got a medication. We will get there. But in the meantime, as Nim was saying, we do not want patients held up by barriers because they don't know what a pharmacy benefit manager is or who their group plan is. So this patient playbook will house definitions, as Nim said, you know, a sample appeal letter, a place to record your medications and your dates and your doses, because you all know, and Lindsay, you've probably experienced this, you get in, well, your plan is asking you to have tried and failed others, and until the plans adopt the AHS position statement, and I suppose, I hate to say this, but they don't have to adopt it right away, right? We still want patients to be prepared and ready for this prior authorization process, because it's really a challenge, and it just, as I said earlier, it adds to the stigma that we are forcing our patients to take off-label medications when we have, you know, disease-specific targeted therapy available, which has been founded and taught us a lot about science of migraine. You know, in the drug development part of science, we're learning what migraine really is. So I think that prior auth is important. I'm sure Dr. Degree, Dr. Hawker, seeing you from a provider perspective, prior authorization is just, it's a nightmare.
Well, we've had to get an entire team to work on prior authorization. Costly, several people working on this all the time. And I would like to just say, it's helpful to us as providers when patients come with a list of medicines, what dose they were on, how long they were, because then we can advocate and say, well, they were on this, and those weren't very helpful. It didn't work very well, and it's really a team effort. I mean, our organization has put the resources in to get pre-authorization so that we can put people on certain medications or devices or whatever for prevention or acute treatment. But it really helps us when the patient comes prepared with a list of what they've been on and what happened. And so I'd urge everybody to kind of keep your own kind of record, because not everybody, the provider may not have access to your previous records.
There are some great resources for patients to do that as well. So I always say, if you like old school, want to do it paper and pen, that's totally fine. But there are some great apps. In fact, I have always tracked these things, and I was able to create a PDF from my app and share that with my doctor. And so she was, it was great for our conversation, but then that did help with the insurance issue as well. So I think that's really important to note. And I think it also empowers the patient to feel like they're able to tell their migraine story, which is so important. And to really recognize, when we're talking about how many days are affected by headache, that really lets you see the reality. And for both myself and my doctor, that was just eye-opening. So I definitely encourage people to do that. It's worth the time.
Mm-hmm.
I'll just add one point to this, because at my practice, it's very similar to Dr. DeGray's, that we have a whole team that does prior authorizations, and sometimes patients will come and say they've never tried anything. But as we know, many people might have high blood pressure, or maybe they've had depression or anxiety while they've lived with migraines. So I'll ask them, well, have you ever been on antidepressant for any reason? And my patient might say, well, yes, I was on this medicine and I had horrible side effects to it. Well, I need to know that, even if it wasn't prescribed for migraine, right? Because I'm not going to prescribe that medicine. Maybe it's a side effect now, and I need to know that, and I can document that for the health insurance. Or maybe they were on a blood pressure medicine and that caused terrible side effects. I want to know that. Or recently I had a patient who had neuropathy, and they were on a medicine for that, which we can use for migraine, and I documented that as well. So all of those things can be helpful. And I think as clinicians, if a patient comes and says, I've never been on anything for migraine, but we see that the patient has high blood pressure or depression or neuropathy or those other things, we can ask questions about what medicines they took for those problems too.
Yeah, it's such an important part of the history, and it's such a great point that many patients have tried medicines and the medicines have failed them, even if it was for a different purpose. And it also raises the point that some of the old medicines might be the right choice if someone has a neuropathy. Maybe they do need to be on one of the old standard therapies that will help migraine and help the neuropathy. Maybe the neuropathy gets better, the migraine didn't, and so we have this ammunition. So I think this, we're just down to the final minutes, and I'll just get everybody's last thought on what they wanted to share. But I think the message here is, we are all here to empower you as patients. We're all here to improve your life as you live with migraine. It's in the DNA. We don't yet have a way to eliminate it, but we're all working toward the same common goal. And so we appreciate your time with us. Any last thoughts, Dr. DeGray?
Yeah, I want to just say, and we're working to educate providers. The American Headache Society holds a scientific meeting every year and a kind of clinically oriented meeting every year. And we are here to educate providers and the next generation, and we're working hard at it because we want to cure migraine.
Dr.
I'll also add that.
Go ahead, yeah.
Yeah, I'd also like to add that we will be sending out the link to the position statement that we've spoken to tonight. We promoted it earlier, but we'll continue to promote it. Please read it, and if you're having difficulty understanding it, you can reach out to the American Migraine Foundation info email. We could also help you understand how to talk to your provider and point you into proper resources for that as well.
Absolutely. Dr. Hawker-Singh?
I just want to thank the patient advocacy committee and the patient and advocacy community, because we're all in this fight together. I think this position statement update is really, really important, and it really came about because of the strong voices of all of you that really empowered us to put this together. So thank you for that.
Lindsay?
I just want to reiterate to patients that, again, it is a team effort. And so I would encourage you, take some notes to your doctor appointments, because sometimes when we're there, all we can think about is the pain, and we forget the pieces of the puzzle that can help decrease that and lead us to a better life. So I think it is important to be prepared, and again, to share your migraine story, how it's impacting every area of your life, because maybe you're not doing quite as well as you think when you really lay out all the details, and hopefully that's what's going to change for people. So it's very exciting.
Yeah, and it's a great point to share your story, and it's hard to talk about it, but AHS and AMF, we both work on, helping patients talk about their migraine story, whether it's with family members, there's a lot of resources on AMF, or you need to, as Nim said earlier, approach HR. How do you talk to your boss about migraine? AMF is working hard on how to change that corporate environment, and part of prior authorization and the multi-stakeholder is to educate some of our corporations about, do you know what drugs you have available on your plan for your patients with migraine? And did you know that you don't have targeted therapy as a first-line choice on your plan? And then did you realize that this could result in higher presenteeism, higher absenteeism in your workforce? And while at the multi-stakeholder that Nim mentioned before, some of the companies, we'll just pull somebody off at another line. But the point is, that person with migraine might be leading a project. They might be launching an initiative that day. They could be a truck driver who's got to get on the road and deliver the goods in urgent time. So we're all here for the same purpose, where I'm very excited, to be in the field at this time. It's not an exciting time to have migraine, but it's an exciting time to help those living with migraine to make change. And we're here to support you. So always feel free to reach out, to contact AMF, or certainly there's some fabulous educational resources. If you have a good relationship with your provider, to talk to them and send them over to AHS. And I thank everybody for your attention this evening. We really appreciate you joining us. Thank you.